So if we can trace on a map with the person in front of us where that pain goes all the way around to the spine, we can actually apply the cream at that side of the spine as well as it's entering into the spinal column.
No condition gives more relief when treated sufficiently to both patient and physician than chronic pain. Every day, the problem of pain plagues millions of people in our society. Pain decreases our productivity and our ability to enjoy life. Pain interferes with our sleep and our ability to manage day-to-day tasks, and some studies have shown that pain that interferes with daily life can also be associated with an increased risk of mortality. Traditional medicine will often treat pain with an anti-inflammatory or analgesic like acetaminophen. If these do not work, often the person is prescribed a stronger anti-inflammatory medication. And if the pain persists or does not respond to these medications, prescribers often feel there is little choice but to resort to opioids like morphine, oxycodone, and hydromorphone. All of these medications come with their own set of contraindications and possible drug interactions, and none of them are without side effects. In the words of today's guest, pharmacist Graham Mackenzie, this has resulted in an opioid epidemic that has destroyed lives and shattered the public's belief in the pharmaceutical system. This begs the question, what if there was another option? What if there was a way to develop a formula for each patient's specific type of pain? A formula that would target pain-transmitting nerves at many different receptors without the side effects incurred by the oral ingestion of the same medications. This is the work of today's guest, pharmacist and pharmacy owner, Graham Mackenzie. Graham Mackenzie graduated from St. Francis Xavier University in Antigonish, Nova Scotia in 1989 with a Bachelor's of Science in Chemistry. He then graduated in 1993 from Dalhousie College of Pharmacy in Halifax. Graham is a pharmacist and a pharmacy owner. He also recently authored the book called Healthy Logic, Evidence-Based Healthy Aging. During his time in Halifax, Graham worked for a compounding pharmacy and learned the basics of pharmaceutical compounding. He now supplies compounds to hundreds of patients in Nova Scotia and beyond. Today, he will share with us how his compounding services have helped patients effectively manage pain without the systemic side effects that are often a very challenging problem in pain management. Graham, thank you so much for joining us today.
Thanks for having me, Lindsay. It's good to be here.
Could you tell us a little bit about where you're from, what type of work you do, and what your day-to-day looks like?
Yeah, so I'm originally from Sydney, Nova Scotia, and this is Badek, which is just under an hour away from Sydney. And I came here when I graduated in '93 from Dalhousie. And during the time at Dalhousie, I actually worked for a store that was listed as a compounding pharmacy, which was pretty rare at the time, especially in Nova Scotia. And Byron Sarson was the owner of that store, and kind of got a feel for what compounding was. So when I came here, it wasn't until 2001 that I actually purchased the pharmacy. And it was another maybe 8 or 9 years before I really fully brought compounding into it. And so I started slowly, collecting all the gear I needed for it. And after a while, we redid the whole dispensary and I put in a compounding lab. So my own day-to-day world is usually doing compounding. I'm the one that does most of the compounding. And some stores will hand it off to somebody like a technician or an assistant, but it's part of the job that I found. It made it interesting again to do compounding. And so I've kind of wrote myself into that corner where now I always have to kind of catch up on that, but it's fun. And a lot of doctors in the area have really kind of embraced compounding. And it's a troubleshooting oriented part of the job, and physicians will just call and leave you just open-ended questions of how their patients could be helped with something that they can't get commercially.
And so you just touched on that, but I was just going to ask you, for those who don't know what compounding is, could you tell us what that is and what kind of service that is?
Yeah, so pretty well any pharmacy can do compounding, and typically what we would see in compounding is you would take, hydrocortisone, salicylic acid, coal tar, and Vaseline, or you'd mix 2 creams together, and that was compounding. a step beyond that, to actually be what's referred to as a compounding store, is you make a lot more than that. So you start from scratch with raw ingredients. Typically, you're using powdered form instead of grinding up tablets. You're taking things to make them into lollipops, into pre-filled syringes of cream. We could be doing suppositories. Capsules are very common now. We have 4 different size capsule machines that we make, and almost every day we're using that. So these are things that you don't typically see. Capsules are something that I suppose you would see in some stores, but even around here, I noticed there are some pharmacies getting away from that, and we're seem to be getting more people asking us to make those dosage forms. For sure, pain cream by far, I would say, is 3/4 of what we do. That's for all types of pain, palliative care pain, and soft tissue and nerve joint pain. Really, any type of pain that's out there, we get asked to help treat.
Yeah, because pain is a very complex issue, and it's often quite complicated to treat it. And you even say, so the reason that I asked you to come on today was because you've written this book called Healthy Logic, Evidence-Based Healthy Aging. But there's a whole section in this book devoted to speaking about compounding and how compounding can address these issues of pain. And you actually say in the book that overall, the number one reason that you see in your practice for decreased quality of life, lost work time, and increased cost of rehabilitation is pain. What do you think that we could do differently as a society to better address those who suffer from pain? And I know that your solutions at your pharmacy are part of a solution.
Yeah, so we always combine, we don't turn our back on commercially available things, and it's always important to if there's something there, we're not going to be compounding it. But as far as improving pain relief, I think there needs to be more research on different ways to treat pain. So that's number one, and that's something that's kind of out of reach for most pharmacists. But secondarily, though, I think understanding where pain is coming from instead of treating, a sore muscle, understanding where that pain is coming from, why it's happening. Physicians are very big on bringing in physiotherapists, which are a huge, huge help in pain. But myofascial pain and trigger point pain and understanding how to deal with pain, even without direct medication, sometimes can be a huge benefit for the patient. So, you have somebody with a headache and we're treating them with our anti-inflammatories, and, God forbid, we're giving them some opioids if it's really bad. But if we could really dig deeper into the initial cause of that pain, and if there are trigger points in a muscle that are causing a headache, and it could be something as simple as treating that. And this is just one example, but I think just to open our mind as to what is causing the pain, it's expensive to really dig deep into a patient to figure out why that person's in pain when we have a clear x-ray and we have a clear scan and nothing's really showing up. So there's not much in our toolboxes to treat pain these days, and this is a huge option we have is to find out the cause of the pain and treat that.
Mm-hmm. Mm-hmm. Yeah, that's really interesting. One of the things you mentioned in the book that I had not heard of is using omega-3 supplements for pain. What is the evidence for that, and how have you seen that work with your patients?
So omega-3 supplements, or not just supplements, but increasing omega-3 in your diet has been shown to work very similarly to how prescription anti-inflammatories work. So with increased omega-3, which we really need, because since the start of last century, we really have increased our omega-6 in our diet quite a bit, which is very pro-inflammatory. To increase our omega-6 either through diet or supplementation, we can very easily and quite side effect free treat a lot of pain. So I have a woman here in Bedak. She's 100 years old. She has arthritis, and she's just one of these patients that we all have that doesn't want to take medication. I don't want to take anything for it, but her quality of life is gone. So We gave her omega-3. Did it change her life 180 degrees? It didn't, but it was pain relief enough that she was able to get up and move around and get into the community. So there is lots of evidence out there, and Lindsay would be happy to share any studies that I have with you. But the makeup of the nerve cell, like nerve pain, for instance, the more omega-3 that we could have in the membranes of these types of tissues, and following how omega-3 actually works we have the COX-2 and the LOX systems, which pharmacists are familiar with, because this is how we treat pain ourselves. Nerve pain, tough to treat, and even with anti-inflammatories, we have difficulty treating pain because prostaglandin might have something to do with introducing the nerve pain in a patient, but as that nerve pain continues, prostaglandins have very little to do with that. So sometimes NSAIDs have very little effect on it. Omega-3 on a whole cascade of things has been shown in multiple studies to help with pain relief, not just through prostaglandins, but through a number of mediators that are in pain, like leukotrienes and a lot of mediators that we really don't explore a whole lot when we're treating things with just NSAIDs.
Mm-hmm, mm-hmm. Oh, it's very.
So I'm a big fan of omega-3, and again, there's lots of ways to get omega-3, but in this vegetable oil society that we're in, it's pretty difficult to say that your diet is high in omega-3.
Yeah, and your book talks a lot about diet as well, and different things that we can do to help improve our diet and nutrition, which is quite helpful. You also mentioned in the book micronutrient deficiencies, or any deficiencies that could make, are there deficiencies that could make a person more susceptible to pain or more sensitive to pain?
Yeah, so there are a few nutrients that have been used and studied for pain. So B12 for nerve pain is one of them. Folic acid is an interesting one, which has been very well studied for pain and pain relief, to the point that it's been prescribed for patients for pain sometimes. Magnesium is one of my go-to ones, especially for leg cramps. I suppose if you really dig deeper, if you look at B complex and vitamin C, these have been used in studies for pain. And as far as deficiencies, when we're looking at deficiencies in that chapter in the book, it refers to pretty well every medication has a downstream effect on reducing some micronutrient in your body. And the question is, how statistically significant or clinically significant is that going to be in the patient? In most patients, it's not a big deal. Although I think if you look at the fact that most pharmacists would agree that B12 is probably one of our biggest supplements that we sell.
Yeah.
At least half of the medications out there deplete B12. And when you're trying to treat pain, and I'm not saying that everybody that takes B12 is going to be able to treat their pain, but if it's depletion of B12 causing the pain, it's very quick to fix that. So it's a necessary evil. We know that some of these things are depleted, and clinically, I guess it's not going to be a big deal for some, but we have already seen that in that one nutrient alone, that that depletion has huge effects on our patients.
Mm-hmm. Yeah, it is a huge issue, and it's very easy to find out if someone has a B12 deficiency. It's a very easy blood test, but also just from their looking at their medications, you can see who would be more susceptible, right? It's an important thing.
It's really something that I typically, and I'm guilty of this too, is how many times that you're counseling a patient that you say, your iron might be low because you're on this PPI, you should get your iron checked. But it's something that at least should be in the back of our head, that if someone comes to us and say, I'm really tired lately, it's almost like if someone comes to you and they have a chronic cough, well, as a pharmacist, you're thinking, okay, are you on an ACE inhibitor? Well, if someone's as a pharmacist, we're thinking, is it a drug-related problem? So if someone's tired, it's very easy to think that a medication could be doing it.
Yeah, such a simple solution. And it's not expensive either. It's very easy to
No, not at
try.
all.
When you're working with patients at your pharmacy that are dealing with pain, and you've addressed the other possible sources or problems, and the physician has diagnosed them with pain, and they come in looking for options. You have, like you said, these creams that you do compound, but there's certain types of pain that are better treated with these creams, and certain types that are not. So what types of pain are more successfully treated with a topical, say, versus an oral, and what are the advantages of a topical medication over an oral medication?
Well, I guess to address the advantages, some of these creams, in fact, the most common cream that we make is has 6 ingredients in it.
Wow.
And it's pretty difficult to take 6 active ingredients orally and continue on with that without a side effect that's going to take you off of them. So the most common side effect that we're going to see is rash. And it's pretty rare, even on broken skin, that we're going to see even blood levels or side effects that would be significant at all. I did have a woman that, all over body pain is difficult to treat. So we usually get people to pick a couple of spots that are really bad for them. And she went home and it worked on a couple of spots. And then she said, okay, I'm going to put it from the neck right down to my feet, and covered herself with it. And so this lady, you can imagine the surface area involved here.
Yes.
She fell asleep almost immediately, and she slept for probably 8 to 12 hours, had crazy dreams the whole time, and woke up, very refreshed. But this is what can happen if you put it on a very large surface area. Typically, we don't see too much of this happen. With amitriptyline, there have been cases where there have been heart rate changes. And beyond that, really, rash is the biggest thing that we see happening. And rash happens more if you combine the cream with like a tensor wrap or some sort of if you have something that you're putting on your knee and you cover it with a wrap, that tends to give more of a rash than others. As far as the types of pain, as I mentioned, one of the most difficult types of pain to treat is neuropathic pain.
Mm-hmm.
I have had people try, especially diabetic neuropathy, on their feet, and we give them the strongest thing we have. And it's just like putting water on it. And it's really tough for these people. But you always get some people that does respond to. We do have really good effect with postherpetic neuralgia. There's that type of nerve pain seems to be fairly well treated, and TMJ was the jaw joint. We really noticed with dentists, they were having a lot of luck with that pain cream. So the patient would get in the chair, they wouldn't be able to even open their mouth, because there are some people that it is that bad that they can't even open their mouth. So they would put the cream on both sides and let it sit there for 10 or 15 minutes, and then they could work on the patient. So that type of pain we had a lot of luck with. Yeah, cancer pain. So cancer pain is going to be one of the most difficult and toughest pains as far as on a scale of 1 to 10. And we have a lot of luck with that type of pain. And transdermal, you can apply a active ingredient that will really get down to the bone. So we can really push this into the skin and into the tissue. So yeah, cancer pain really works well. Arthritis, as long as we're not putting it on a bunch of joints at a time, we have some people that will rub it on a hand, but if it's, both shoulders, both elbows, both knees, we usually get somebody to pick the worst spots and put those on. So arthritic pain is pretty well tolerated. Soft tissue pain and just regular pulled muscles, and usually it's the back that we see this used with, responds fairly well. And I'm a big fan of, again, to go back to trigger points, I'm a big fan of stretching for and it doesn't have to be like a crazy stretch. I think it's more the repetitive nature of the stretch rather than how much you're actually pushing yourself to help with a tight muscle. Those are the biggest ones we see. And again, the nerve pain is always a challenge for us. If we could get something to combine with it. Usually it's an oral product that will work on the nerve, and combine that with transdermal.
And when you use these creams, you're often using multiple ingredients. What are the most common ingredients that you're having success with?
So almost every one of them will have an anti-inflammatory. So that would either be ketoprofen or diclofenac, and it's usually in the strength of about 5 to 10%, usually 10. And we'll use amitriptyline from 3 to 10%. Clonidine is almost always about a 0.1. And then we'll use gabapentin. There's not too many times we'll use gabapentin in a higher concentration than 6%. And lidocaine, about 3% is pretty standard, I guess, for 2 or 3% is what we use. So those are the main ones. We'll also use cyclobenzaprine sometimes, and carbamazepine is another one that we'll use. Lorazepam actually works really well, especially with like vulvodynia or rectal pain, mucosal membrane pain. Lorazepam works really well for that. And yeah, those are, I would think, that's probably 90% of what we're using. And there's always these weird ones that they all act on the nerve in different ways. And that's why we use so many of them, because the more areas in the nerve and the more gates that we close through different pathways, and the more successful we are. So there's actually studies that show that dextromethorphan closes down channels, and as does guaifenesin just for pain. So we don't use those a whole lot, but when we're really, really stuck and the doctor just wants to try something else, sometimes we'll add these in, and they'll work. So a shotgun approach is probably going to work better for you. Having said that, we have a lot of people that just take the 10% diclofenac and it works fine for them.
And so when you're using these topical creams with often multiple active ingredients, can you explain to us a little bit about, I know you were part of a study, it was called a transdermal penetration study, but can you explain to us what is happening in the skin when we apply this to the skin? Because a lot of us would just think that it kind of just has a superficial effect, right?
Yep.
What are we actually doing to the skin and to the nerves and muscle tissue that are in there?
So what we're doing to get the actual ingredient through the skin, there's different ways to do it. We can do it in a way that has liposomes, which are little lipid balls, for lack of a better description, that carry the active ingredient through the top thicker layers of the skin, which are more kind of a lipid type of a environment, and then they get down below that, which is more water based. That's one way to do it. The other is just to use penetration enhancers that are included in transdermal products. So a lot of the thinking as far as how am I going to get it through the skin is removed when you rely on these compounding companies like PCCA and Medisca. They have transdermal creams that will do the job, and we know that the formulas that they have are good for a certain amount of time. As that study shows, I took 3 of those creams, and from different companies, and I put the 6 ingredients in them. Because one of the arguments was, how can you put 6 ingredients through the skin at one time?
Yeah.
Turns out you can, and without getting into a whole lot of the detail of which did better and which went through more in what cream. This study is being duplicated now. It's going to show the amount of each of those ingredients that I mentioned to you in 3 separate commonly used compounding transdermal creams. And so it was finished, and I think we were almost at the point of publishing that study from the College of Cape Breton here, just an hour away. And they said, you know what, I think what we're going to do is we're going to redo this study, and we're going to make sure, because a duplicated study really means a lot, and with this many ingredients, they want to make sure they had it right. And they're in the middle now of doing that, and hopefully after, I think we've been at this for probably 4 years now at least, they're going to have something finished that they could publish.
Yeah, because I imagine there's a lot of hesitation when you tell a prescriber that you can offer a pain solution, but it's got like 5 or 6 different ingredients in it. That probably
Yeah.
kind of blows their mind.
Yeah, I remember the palliative care doctor, Dr. Ritter here in Cape Breton, and he is always such a big fan of, trying things that we haven't tried before. And he had a student that had just graduated, and so we sat down in this room, and he said, "Okay, what are we going to do?" And by the end of it, we had 5 ingredients, and nothing is duplicated as far as what channels in the nerve it's gonna block. And I could just tell by the look on his face. He said, like, it's almost like we were kind of making up some sort of a voodoo concoction that we were going to give this person. But I think it takes one patient and a doctor just to convince them. All it takes is just the one patient, and you really kind of have them on your side. And although a lot of these ingredients could be considered to be anti-inflammatory or a muscle relaxant, the main reason they work is they block the transmission of the pain through the nerve up to the brain. So if you can do that, then really it almost doesn't matter what kind of pain you're treating, because it all travels to the brain the same way. And you get those few ideas across to the doctor, and it could be, quite often it's either a family member of the doctor, or it's the secretary at the doctor's office that wanted to try it, and then they become very comfortable writing it.
Yeah, that's interesting, overcoming that. Well, I mean, if you have evidence, and if you even just have in your practice, right, success stories, and how this is likely even safer than, say, an oral treatment. Like you said, how are you going to take 5 or 6 different medications orally and not have some kind of either drug interaction or side effect or adverse outcome, right? What about for patients who are more sensitive to, like maybe more prone to allergies? You said generally the side effects are mainly just a rash. Some other people, if you put a lot of it on, yes, you could get more drastic side effect.
Yeah, you can have an allergy to these things, and this is what makes it tougher when you're using 6 ingredients and someone comes back and they have a rash and they didn't use a wrap or anything like that. Then what we have actually done is we've gone each ingredient at a time, starting just with the base. We'll say, okay, here's the base, put this on for a few days, let me know what happens. And then there's always a couple of ingredients that are more common sources of allergies than others. So we'll start with, the ones that aren't, and we'll start with the lower strength. And it can be a long process to do this. By the time you get up to, okay, we're at the 3rd ingredient now, and we kind of work up from there. And if they have pain relief with that, then we can just stop without even really knowing what the offending agent was. But this is the reason why the shotgun approach is so important, because if we were starting from scratch, with 6 ingredients, starting at a low dose and working our way up, you can imagine not only how long that would take, but how much money it would take to have all of those prescriptions filled. And so are we overdoing it with these patients by giving them all these ingredients that may be a strength that maybe we didn't need? It's quite possible that we are. And we're always open as pharmacists to having the least amount of medication being used at the lowest strength. And quite often some doctors will start to cut back. They'll say, why don't we just take the ketamine? Because ketamine is a very commonly used product in this. Let's cut it from 10 to 5 and see what happens, and go from there. Sometimes just the fact that the patient knows that something's getting changed is enough to make them get their pain back again, unfortunately. But most patients are pretty open to that, and they'll settle in on a strength that works for them and the number of ingredients that works for them.
One of the other things you mentioned is that you've had success in using these creams for wound care, and you mentioned using aloe vera and honey. How are these beneficial in wound care?
So we have honey for most pharmacists that we've seen in our wound care section grow over the last 10 years, and honey has been found to be quite active in wound care. And there's a lot of different things in honey that do that. The low water content in honey, the water activity is, I believe, 0.91, and I think once you get down to 0.85, you're almost antimicrobial. So once you get down to 0.85, you're pretty much at antimicrobial. But inside honey, you've got not only the sugars, but you've got flavonoids and organic acids and phenolic acid. There's vitamins and enzymes, and they all deal with wound healing. The osmotic gradient that honey offers will actually draw water up from the tissue to help debride the tissue.
Wow.
And covers it. The low pH will help with oxygenation. And this isn't something that we came up with. This is something that's commercially available. So as far as compounding, we don't do a lot of compounding with honey, but there are a couple of bases that are out there that will use similar ingredients. Meadowsweet is a plant extract that's used with phenolic compounds and flavonoids and just protectant. Honey itself, part of its mode of action is just that it protects the area too. And aloe vera, I mean, the anti-inflammatory, vasodilator, it's antimicrobial, proliferative for wound care, and these are very simple, plant-based ingredients. So we will use aloe vera in some wound care. Most of our wound care uses not just pain relief like lidocaine, but you can actually put nifedipine, nifedipine into something to help around the margin of the wound to help with blood flow. Phenatone helps with tissue growth. If we have patients that are on phenatone, and you can tell by their gums what it does with tissue growth, and it does the same thing topically as well. So we try not to put too much into as far as concentration wise into the wound care products, because it's just such an open area. But you can really help to get an area closed over relatively quickly with the right compound. I think most of the palliative care doctors they're not looking at getting an area grown back together again. They're just trying to keep the patient comfortable. But even palliative care doctors have taken advantage at least of some of the wound enhancing properties, especially if they're bedridden and they have bed sores. You can heal up stuff very quickly with the right compound.
Yeah, and it's so important that people know that pharmacists can do this. We're not just restricted to what we have in our dispensary or what's out there in the in our front store section, right? It's something that, I mean, not all pharmacists do this to the extent that you are doing it, but it is an option for them to discuss with their doctor if they're struggling with pain or something like that. Mm-hmm.
Yeah. So it's important to make sure that the pharmacies in your area have that, knowledge that you're able at least to do it. And pretty well all the ones around here are on board with, they know that if it's not going to be the thing that they do, they'll send them to us. And as we would if there was something they were doing that we weren't doing. We tried to do this initially without any kind of what I would call a drug rep, but we have hired a traveler that used to work in the industry of generic drugs, seeing doctors all the time, and so it's worked out well. It's at least given us kind of a voice out there that doctors wouldn't have, and if anything, it helps to bring up questions that they can get answered very quickly, rather than kind of wondering and not even getting in touch with us. So it's always good to have that extra person out there to help market the whole thing.
Yeah, that's really good, because I'm sure prescribers want to be educated before they're prescribing. So that probably helps them feel more comfortable with where you're coming from.
So we give them some tools. Like there's, with the most common pain cream, what we have a sticker that we can just, with the directions on it and everything. And all they got to do is put that on there and sign the name to the prescription. And the way it is now with verbal and faxing of narcotics, it makes it much easier to get these things in a timely way to the patient if they're palliative, especially. Because it used to be, you have to have the prescription in your hand. You can't phone it in, you can't fax it in. But with COVID, if there's any silver lining that came out of that, it just made it so much easier to get these prescriptions to the patient, even to the point that we are allowed to, in this part of the country at least, prescribe, even if there was a narcotic in it. So it's not something we really do a whole lot, but if the need was there, at least we were able to do it.
Yeah, it's incredibly important, especially for patients who are palliative or who are in need of something, urgently, that can't wait, a week or two to see their doctor or something like that.
True.
Yeah. You also mentioned in your book the use of dermatome maps, and you found those to be useful when addressing pain. What are dermatome maps and how are those useful?
Well, if you Google the term dermatome map, you'll see what looks like bands across the body and down the legs. And dermatome maps, I suppose, in the pharmacist world would be most common with shingles. So the chickenpox virus hides in the root of the nerve in the spine, and it just decides one day I'm coming out, and it comes out along that nerve, and where that dermatome comes out, that's the band that is called the dermatome. And that's, so in that case, that's it almost becomes visual, that band. We use dermatomes when we're trying to treat pain in larger areas that aren't getting treated very well by direct application of the cream. So if we can trace on a map with the person in front of us, we can trace on a map where that pain goes all the way around to the spine, we can actually apply the cream at that side of the spine as well as it's entering into the spine. So we can treat it in two areas. So if I have, a sore shoulder and I'm getting some relief putting it on there, and I can show them the spot exactly on their back where that nerve is going in, they can put the cream right there as well. So you don't get as much relief doing that, but dermatome maps are and there's also myotome, like muscle maps as well, but the dermatome ones are probably, I would say, 10 to 1 more commonly used.
Can you tell us a story or something of a patient that you were able to help with your compounding?
Yeah, we have Sandra, I recall, was a patient that we had that she had multiple injuries and lots of different surgeries. So she had a lot of adhesions. So we're talking visceral pain, which can be difficult to treat topically. But this lady was on 624 morphine equivalents per day. So this is a lot. Wow. She was on hydromorphone. When it gets over 90, there's a red flag that goes up these days. So we gave her the standard cream that I mentioned to you, and that patient got down to 144 morphine equivalents per day, and obviously was much clearer. And anytime you can get somebody down close to 100 in morphine equivalents, then they're much better off. So yeah, that patient, we're very happy with how that worked. We had another lady, Andrea. I think she had vulvodynia, is a common ailment that physicians will come to us, and so she had a severe case of vulvodynia, and she couldn't be in the office without crying. She was, for the most part, had no relief day or night. And I think with her, we ended up putting the lorazepam in a mucilax space. A mucilax adheres to mucosal tissue, and with some gabapentin and some ketamine and amitriptyline. And she put that on 2 to 4 times a day, which every day, is a lot when you're thinking of putting this on every day. But her world has completely changed around. She was able to go out and shop and go to lunch with her friends. She was just in her home and unable to leave before. And the TMJ, again, there's so many success stories with TMJ. I had one lady that couldn't even have the window open when she was sleeping, because even the small amount of air that would come in through the window would just leave her in excruciating pain. So she was bedridden a lot, and that was the same cream we used with her too, the common one that we use. And once I got into the tissue, she wasn't using it 4 times a day, maybe 1 or 2 times a day for her. So there's always a few people it just doesn't do anything for, but really it's just so awesome when their life changes because of a pain cream you gave them. That's awesome.
Yeah, that would be so rewarding. And I think for people listening, I mean, we see the difficulty in treating, pharmacists see the difficulty in treating pain daily. We see patients who are on increasingly higher and higher doses of medications, say even like a gabapentin or something like that. And there's, as the
Yeah,
doses increase, we see the side effects increase, right?
yeah,
Being
exactly.
able to have an impact on a person like that and treating them topically, I can totally see how that can be life changing for someone.
Yeah, and some people are. Once you get into the nerve acting agents like Lyrica, I mean, there's so many of us that have seen a patient go on Lyrica and it just came off of it within a couple of months because of the side effects. And transdermal, it's not the answer to everything, but it's certainly when it works. The quality of life, not just from the pain relief standpoint, but from the lack of side effect standpoint, can be really, it can just be amazing for that person.
It's really
Yeah.
incredible work you're doing. And I'll just say again, this is the book that Graham has written, Healthy Logic. I'm going to buy it for all of my friends and family because it's so rich. There's so much more than just the compounding that we're talking about today.
Yeah.
But Graham, for someone who's listening and is maybe struggling with pain themselves, how would you suggest that they maybe approach their healthcare provider, their prescriber, about maybe a topical solution that might not be top of mind for a healthcare provider? How do you suggest they approach that conversation if they don't live close to someone like you?
Well, sometimes you have to do a little bit of homework on your own.
Yeah.
So if you can find out for sure that there is a compounding pharmacy in your area, and I can tell this is how some people have started with us, they just Google compounding pharmacy in their area. And so then the next step would be to actually call that pharmacy and speak to the compounding pharmacist. Start the conversation there, and because most of the time we'll offer to at least open up a dialogue with the physician, and we'll know if that doctor is writing for it or not. Sometimes we'll just say, oh yeah, that doctor's very familiar with it, just mention it to them and they'll know what you're talking about. But if it's a new doctor, we'll either send the person that we have on the ground to go in and speak to them. We'll send an introductory fax at least off to the doctor, and then if they're open to a phone call whenever they're free, we can go over just a few things with them. Most of them in this area by now have heard of this pain cream way of dealing with pain. So the only thing that's left is to actually for some of them just to bite the bullet and say, okay, I'm going to try it and see what happens. So I think once you get that groundwork done on your own, at least you can walk into the doctor and say, okay, here's what we've done. I've tried all this for pain. That I don't want to go on opioids yet. And that we've tried these nerve acting agents and I'm having a problem. Would you at least be open to this pharmacy doing something for us? And if a patient is in pain, what I have found is that the doctor will be open to almost anything, especially if that thing is a non-opioid choice. It could be anything, as little as I am in agreement with acupuncture. If the doctor knows it's not going to harm them, and this is what I talk about in the book, the number one thing we should do as pharmacists, as long as something is working, I suppose, where we, with my exception, homeopathy, obviously, because of my history with that and taking it out of the store. But anything else, I mean, I think if the doctor is on board with it, then the pharmacist should be, if it's not going to harm the patient.
Mm-hmm.
If it works, it works. If it doesn't, at least we tried it. But number one, it shouldn't hurt the patient. So if the doctor thinks, this patient's going to get some relief from it, they'll be open to it if it's for pain relief. So it's different for hormone therapy. It's a little different, and we don't do a lot of hormone therapy right now. That is an upward climb for a lot of women, not so much men, but for women, and but for pain relief. I think most doctors are just so happy to have something else in their toolbox they could use, and just to see one patient, just to see what their result is going to be with it. It's not really that big a deal to get a doctor on with this.
Well, you've given us some really great information today, Graham, and I think that a lot of people watching will really appreciate the knowledge that you've shared with us today and the work that you're doing. I hope to talk more with you in the future because you are a wealth of information. We'll put links to your book in the description of this video, and I know you have an article that's published, and we'll put all of the links in the description. But thank you so much for taking some time at the end of a very busy day for you to speak with us about compounding and giving us some solutions that maybe a lot of people haven't thought of it, that how a topical remedy could address some pretty severe pain issues out there.
Yeah, there's always another way to do it, and as even myself, I learn something new almost every day when it comes to stuff like this. So it's not that we're all 100% experts on a topic, but at least we have some background clinical experience just to kind of have a starting point in a lot of this. And I appreciate the opportunity to share this with you and your listeners.
Absolutely. Thank you so much, Graham. Take care.